Hi, everybody. Welcome to Cox Connections. Brad Grundmeyer, Director of Public Government Affairs for Cox, Louisiana. Thank you so much for tuning into our show. In our first segment, we're going to be talking about the issue of health care in the state of Louisiana. Actually, for this segment, we were hoping to have Bruce Greenstein, who is the Secretary of Department of Health and Hospitals. Unfortunately, Bruce had to bow out last minute, but we're actually happy on this segment to be joined by Senator of District 7 in the state of Louisiana, as well as a well-known ophthalmologist, I should say, optometrist, Dr. David Heitmeier. David, welcome, buddy. Good to see you, sir.
Thank you, Brett.
And congratulations. It seems like you've had some great success in the area of health care and services and the issues with public, private, and procure. Let's go back to the beginning. When did you first, and we have as citizens had seen that there was really a red flag in the area of the equities of public health, but or even health care in general. When did you first see that there was an issue, and give me a little bit of an understanding of the situation we were in?
Well, I was elected in 2008, and
so you've done this in a little bit of time.
And what happens when you started to understand what's taking place, Katrina really affected healthcare delivery, in our region. And the hospitals that we were focused on was, of course, the ones in the West Bank in my district, was West Jefferson and Ochsner. And West Jefferson at that time was starting to go through cash. The payer mix changed. They were now seeing a lot of patients on compensated care and also a significant increase in Medicaid. The state pays hospitals below the cost to provide care under Medicaid.
So right off the bat, the hospital is not going to make any money.
Correct. Yeah. And so it was just a complete inequity what was taking place with those hospitals because of the change in the payer mix. And then on top of that, we were facing budget cuts. Yeah. And everyone knows that budget cuts, the things that are affected are higher education and healthcare. And so healthcare was getting killed, and the hospitals were getting cut reimbursement of north of 20% plus. Right. So it was something that we had to stabilize. And so I started to look at the financing mechanism of what were some options that existed. And with a lot of bright people and due diligence and stuff, we were able to come up with some new creative out of the box ways of looking at financing. What happens in 1999, Congress said that you can pay hospitals up to the cost of providing the care. So that is called the upper payment limit, which you can pay them as up to their cost. But what was taking place is the way Medicaid works, Louisiana puts up 30 cents. Then we draw down 70 cents from the feds. Right. Well, we were running out of the 30 cents.
It was gone.
So we developed a public-private partnership to start looking at ways, creative financing ways to help our healthcare financing. And a lot of the private hospitals stepped up, and they developed nonprofit entities to start doing some low-income, needy charitable services. And in turn, that makes them eligible for an upper payment limit supplemental payment from the state.
Awesome. And as you're saying, because really what we're looking at is post-Katrina, no charity hospital, so people were just going to the nearest hospital, walking in the emergency room, and the services that were usually done at charity now are being done at the hospitals, which aren't going to refuse citizens who come in there, but still there's a cost associated, so that's a little bit
significant cost. Yeah, you have EMTALA, they have to see patients.
Now you have a few programs. One that I was reading about with these UPLs and this upper payment limit. The first one, which is really interesting, is the one about where am I at?
It's the LINCA program.
Yeah, it's the LINCA, Low Income and Needy Care Collaboration. Tell me about that.
What happens is the private hospitals, we formed a public-private collaboration with public and private hospitals, and they agree, the nonprofit agrees to do low-income, needy charitable services for our state. In return, it makes them eligible for an upper payment limit. So, for instance, there were some things that the state was paying for that the nonprofit entity would then pick up those contracts of those services, which will free up state general fund.
Now this is for private hospitals, this one?
It was for private hospitals for mostly, and to date, we have made over $190 million in payments to the hospitals. Again, they had the 25% cuts. So this was able to try to make those hospitals whole, because not only are our hospitals providing healthcare services, but it's also an economic engine for jobs and economic development for our community.
And as such, also, then you created what is basically called the public house UPL, public hospital UPL. Same thing, which the other one was for private, this one's for public.
Correct. And there's also the physician UPL, which what happens is it's for physicians that were treating patients from Medicaid at the public hospitals. It creates what's called a delta, the difference between what Medicaid pays and some number, and that was the average commercial rate. And so we were able to make a supplemental payment for those physicians that were willing to treat patients that had Medicaid. And all of this has to be approved through CMS, which is the Centers for Medicare Services. Those two programs have been approved by Medicare, the Centers for Medicare Services, and are in implementation today.
Now, again, that was a supplemental, but on the actual public hospital one, how we're matching dollars drawn down there for that UPL?
What happens with that one is we just passed the legislation this past session, and the state plan amendment has been submitted in June, and we're waiting for an answer from CMS on that program.
And I was reading like the first payments might happen at the end of the year?
We're hopeful. We're hopeful. We have to receive the approval from the federal government, and then we're able to make payments according to the state plan amendment.
You know, David, at first, and we got a few more things to get to, but at first glance, it seems like it's really like going and opening a box full of wires. You know, it's just one tangled mess. Is that just?
It's a complicated process, but what happens is, you know, we're forced to do more with less.
Yeah.
And so this is the largest public-private collaboration in the history of the state.
Right.
So there was a lot of bright people involved in making this happen and just bringing it to fruition to be able to do more with less and provide the services for our residents, for our most vulnerable populations, patients with diabetes, heart disease, stroke, to be able to maintain those services and also create the jobs that our economy needs.
Yeah, because I think that's a good point too. We're talking about healthcare, but also jobs. And we were talking before we started, if you have a 20% reduction and such, jobs are a part of what is reduced.
Yes, it is. Any business, if you cut any business by 20%, you're going to have to start looking at employees.
Yeah, you're going to have to look at the human resource side, and unfortunately, that's employees.
Yes.
The last one, which is of interest, is the ambulance UPL. Again, out of the box thinking here, that's working.
And it is, again, that one is, we're in a process of developing the state plan amendment now. And so hopefully we'll get the state plan amendment developed and then submit it to CMS. And, you know, with keeping our fingers crossed, we should win approval.
You know, I've never known you for being a math or you know, a numbers kind of guy, but you obviously had to dive into this. What in a lump sum do you see rolling this up are we going to be able to provide or save?
Well, it just, again, it's services provided.
Yeah.
And it's only providing the dollars up to the cost. Up to the cost. So what we're limited by is the upper payment limit, which says we can be reimbursed the hospitals up to the cost of providing those services. And so that is the rate limiting step. And I believe we have a little bit over $400 million in the budget going forward.
Yeah, that's what I was trying to wrap my head around. That's $450 million. Amazing. Now I know you know, people like Pat Quinlan at Auctioner and Nancy at West Jeff and Mark at EJ must be just thrilled with this, as well as the regional and more rural hospital as well.
Well, they were involved with it.
Yeah.
You know, we had to bring them on board to make it happen.
But if I recall, these guys have been screaming this for quite some time.
Yes.
You heard them.
Oh, we heard them.
Whether you liked it or not.
You know, I mean, being a healthcare provider myself, I understand what's taking place. And, you know, a 20% cut for a business like a healthcare where your margins are 2 and 3% is an unsustainable event going forward. First, you're going to, as we said, look at our human resources component, and then your infrastructure component, and it's not long before you start having degradation of services. And
what's interesting, we were talking a little bit, we're one of only 2 states that have really implemented this, Texas being one of the others, but it's fantastic. Another great you know, feather in the cap for Louisiana, thinking out of the box and more so being very resourceful with the idea of, you know, pulling these dollars to match for federal dollars. And I mean, it's almost like, why didn't someone think about that before?
You know, there's a lot of moving parts.
No, sure.
A lot of moving parts and a lot of I's to be dotted and T's to be crossed. because we have lots of guidelines to follow. You know, you're not just getting free dollars, it's guidelines, again, it's services.
Right, sure.
So the LINCA program is the Low Income Needy Charitable Services, where, you know, they agree to do low income needy charitable work in return for a possibility for an upper payment limit. The physician UPL, which is for seeing Medicaid patients, and then we have the service district hospital and the ambulance when that's, you know, in the works.
Look, it was like one was not enough. You had to do 4.
And there's hopefully
What's been the reaction? I know Bruce isn't able to be here, but I'm sure the collaboration with the Department of Health and Hospitals has been
great.
Fantastic.
He has been great. You know, he came midterm last year, and he just dove in, and again, he was faced significant cuts. He was handed a tough situation to make it all work. And we now have the hospitals talking with DHH, providers talking with DHH. I feel the environment has changed under Bruce's leadership.
Well, David, congratulations, Senator Heitmeier. Thank you. Congratulations on the UP and all the hard work. Also, most recently recognized by the Senate floor. And the Finance Committee, Joe Chasson, the Senate President at the time, congratulations on your recognition and your passion for healthcare. Greatly appreciated. And come back and see us again. We love to get an update on how we're doing in healthcare. We don't really get a chance many times to chat about it, but it's great to hear all about the great improvements and things moving forward in a positive way. So great to have you.
Always a pleasure, Brad. Anytime.
All right, David. Thank you very much.
Thank you again.
Senator David Heitmeier for this segment of Cox Connections. We'll see you next time. Thanks for watching.